My name is Dr. David Maddy, and I teach at the University of Louisville School of Dentistry. And this is a mini series of lectures that I created designed for dental students that I title Functional Occlusion and Advanced Restorative Concepts. Most of the content of this mini series comes from a book written by Dr. Peter Dawson titled Functional Occlusion From TMJ to Smile Design. There will be some references from a book written by Dr. Occlusion titled Management of Temporal Mandibular Disorders and Occlusion, and there are several animations throughout this mini-series by ByteFX that help illustrate three-dimensionally the complexities that are involved. And there is an icon in each appropriate slide that has a reference from one of these sites. This is lecture number 6 that I titled Green, Yellow, Red, and it is where we start to look at treatment determination. So far in this lecture series, we started by talking about making a diagnosis, and then we spent a few lectures on defining a perfected occlusion and described its advantages and purposes. And then we looked at dysfunction a little bit. We started to look at how teeth can get affected and how muscles and disc can all be affected. And so now we have what could be ideal, we have what could be breakdown. So at this point, we have a patient coming in, and we're going to do an examination to make our diagnosis. And it should be that we should be able to clinically determine some of these things we've already talked about. So we want to start or add to our comprehensive exam, occlusion, and TMD evaluation. We'll start with a good history. We want to have probing questions. Some questions that you might ask could be, has your jaw ever locked so that you could not open more than 1/2 inch? And when you ask that, that isn't just for a few seconds, but maybe think of it as a half hour to a day to multiple days. Has your jaw ever locked when opening wide so you could not close? That's a different condition, but it's a good question to ask. Have you ever had pain in your TMJ? Do either of your TM joints pop when you open or close? Did they used to, but now they don't? Have you ever had a night guard or a splint made? And if so, why? Do you have headaches? Good questions. And then we're going to look at the teeth. And when we look at the teeth, we're going to record some information. And this is just one example. And whatever it is you decide and how you want to record it could be appropriate. But we're looking at these details and we're really in our mind comparing them to a perfected occlusion. So we're going to look at if there's anterior contact or overbite, or if there's any lateral contact and excursions, or wear facets, or is there an dentin exposed? Is there mobilities, abfractions, migrations, all the teeth things about occlusal disease. Then we're going to see if there's a discrepancy between CO and MI. And then we're going to test and we're going to load the joint. We're going to test it for whether or not it's painful or not. And it's called load testing, and we'll talk about that at a later date. But really, we're comparing in our notes to a perfected occlusion within our mind. Then we're going to palpate muscles. We want to, after we look at teeth, we want to now look at muscles. And we're going to grade them on a scale of, let's say, 0 to 3. And I like to start myself in the frontal area because there is no muscle of mastication there. And I'm pushing pretty firm. And I'm giving the patient a sense of the firmness that I'm going to push. And I'm going to ask them if they're having any tenderness. And the answer should be no, because there's no muscle. So that when I work myself back into the temporal area, they'll if they do then have tenderness, and often they will, then they'll know that they didn't at the very beginning. As I'm palpating the temporalis, I'll be looking for trigger points and muscle bands and what we call myofascial pain. And sometimes we can identify referral. And by that, you hold one of those tender areas for 30 to 40 seconds and you ask them to see if the pain radiates into a different area. And it's common to see this. This indicates chronic abused muscles. It's a way to determine if those muscles are incoordinated and spastic. Then we'll palpate the TMJ area, and we'll go with the lateral and the posterior, and it's not near as common to have muscle or palpation tenderness in here as compared to the temporalis area. And then we'll finish with the masseter. The same thing. We're pushing firm and we're looking for areas that are painful upon firm palpation. Then we'll do a range of motion test. We will ask them to open as wide as they can, and we'll look as they're opening if they have any deviations or deflections. And normal maximum opening can be within 40 to 55 millimeters, and we see if they have that kind of range and whether or not there's pain or not pain. And we'll have them go right and left when they're halfway open with the same idea. Have they got normal range? Is it painful? This is data that we're gathering, we're recording to assess the range of motion. We listen for joint sounds. We're checking for repetitive sounds, popping and clicking. And it could be that might be a clinical indication of functional disc displacement. We'll see if there's a history of popping or clicking no longer there. And it could be that might be clinical information that there was functional disc dislocation without reduction. And then we'll ask them if there's a history of a closed or an open lock. If there's a history of a closed lock of reasonable duration, then that could tell us that at one point that had functional dislocation without reduction. And if they locked open and they couldn't close, then that might be an indication of something we call TMJ dislocation, when the condyle goes way over the eminence and can't recapture back. Some common TMD diagnosis that you might see in a general practice. Well, if it's muscle, it's sore muscle, that's acute myalgia, or chronic muscle, which we would call myofascial pain. It might be the joints tender upon palpation, TMJ arthralgia. There might be displacement of the joints. There might be dislocation of the joint. Or you might see other things like premature tooth wear, or headaches, or osteoarthritis, or any type of neuralgias. And so these are some of the common diagnoses that you see. So you've done your exam, you've made some notes. Now you have yourself a clinical assessment and evaluation of their total occlusion and or TMD potential. So the question is, what happens if the occlusion's off? And I refer back to the way that Dr. Cranham expressed it earlier. It could be nothing. Some people adapt, and many will. And so nothing can occur if the occlusion's off. Could be the teeth could migrate, wear, become mobile, could have tooth problems, let's say. It could be that the muscles get sore. It could be the TM joint breaks down, or any combination of 2, 3, or 4. The point being is that we're dealing with force management, and it could be that the occlusion might be responsible for any combination or none at all. So let's think about how to figure this out from a treatment standpoint. And if we think about it, we can, from an occlusion or TMD examination, we can differentiate our patients into two distinct populations. The first would be there's no significant findings on the examination, and that we would call that a negative occlusal examination. Or it could be that we have significant findings in our occlusion TMD examination, and we would call that a positive occlusal exam. So we have two populations right off the bat. If it's a negative occlusal exam, and there's no signs of instability, and the joint's healthy, and we find nothing clinically, then we treat by just working in whatever their MIP is. We're not in concern of condyle position. We're just doing dentistry as to how they have their closure without consideration of the position of the condyle. Don't need to treat something if there's no signs, even though the occlusion could be off. If there's a positive occlusal exam, so now we have instability, we have wear, mobility, migration, maybe sore muscles, and we have verified that that joint is stable, it is not breaking down, then we want to treat the occlusion. We want to work in centric relation, create an ideal scheme. And the third possibility, the second of the positive occlusal exam, is there's signs of instability, but now we get yourself more of a problem within the disc itself, and that medial pole is involved, and maybe there's a disc dislocation, and it's not just a lateral pull. So if we have that, we want to stop, and we want to first treat the joint. And then once that joint is treated, then we treat the occlusion. Sometimes that joint treatment can last up to a year before. But the key is don't do anything to the occlusion if we're red and we have signs of instability that involve the medial pole. The green, we're going to work in maximum intercuspation regardless of the condyle position. In the yellow, we're going to work and treat towards centric relation. And in the red, we're going to stop. We're not going to do any permanent treatment until the joint becomes stable. Let's look at positive occlusal exam a little bit more. And let's say that if they're yellow and we've decided to treat the occlusion and the joint is stable, then an older word we used to call those are extracapsular problems. In other words, outside the disc itself. If, however, it's red and we have instability of the medial pole, we used to call that intracapsular problems. Well, let's look at this one, the yellow. Positive occlusal exam, stable joint, and because this is where most of our treatment will be identified. And so the goal is to choose the most conservative treatment option or options to establish conservative stability. Well, we have some options here. We're speaking in terms of concepts now. This class is not designed to go into all the specific details, but I want to walk you through, though, how to, in your mind, categorize and how to think about treatment possibilities. So we have someone that's yellow, instability, wear mobility, but the joint is stable. We can make them a splint, and sometimes that's a good way to start, particularly if you're not comfortable or confident enough to do something more permanent. But a splint can be quite valuable as a device until something more permanent can be resolved. Another option is to reshape the teeth. We call that an equilibration. We can reposition the teeth, or we can move them through ortho. We can restore the teeth. We can make crowns or fix occlusions with restorative dentistry. Or sometimes we need to reposition the bone. The key point, though, is regardless of the treatment option, the occlusal goals remain the same. So what are the goals? Create stable, equal intensity centric stops on all teeth. Create non-interfering posterior teeth. Create aesthetic anterior contours that do not restrict the envelope of function. 5 different ways to think or combinations of, but one treatment goal. Now, what do we call this when we create these things listed? We've been talking about it in great detail. Well, we call that a perfected occlusion. And so now we have a tool, we have a concept to build towards in order to treat the occlusion. Let's go through a couple quick examples. We're going to reshape the tooth. This is a young man that had he was diagnosed with yellow. His joint was stable. He had a small discrepancy. Everything else was looking good, except he was getting chronic repetitive temporal tension headaches that were associated with this excessive muscle activity from not being able to completely seat his condyle. And so a procedure called an equilibration was done where the teeth were shaped in such a way that the endpoint was a perfected occlusion. Another treatment option is reposition. You have someone that has teeth that are not in good alignment, and there's techniques you can use to increase the speed, like slice some of the buccal areas. But put them in ortho, but you put them in an ortho in a way that when they're done, they're in a perfected occlusion. The condyle completely seats. The canines are in a position that when the right and left lateral occur, immediate posterior disclusion occurs. There is anterior contact, and that when this patient protrudes, there's immediate separation of posterior teeth. So we create a perfected occlusion by moving teeth. Option number, reposition. We can restore teeth. Here's a patient that had some bonding on the front. So it was done in such a way that it was begun with a minor equilibration, and then new crowns were made. And these crowns were made in a way that a perfected occlusion could be finalized. restoring teeth. Sometimes it's so bad we have to reposition bone. And we showed you this example a few times, and there's nothing that could get that into a perfected occlusion without moving bone. So we do some orthodontic surgery, and the surgeon and the orthodontist is involved. So then when it's finished, the ortho is done in a way that a perfected occlusion can occur. Sometimes we've got to do combinations, a combination treatment. So we have a patient here that had some crowns done in the past. And when you look at this patient's mouth and centric occlusion, you see there's a big opening in the front. And so the old crowns were cut off, some temporary transitional crowns were put on, and then ortho was done and moved around, and there was a little surgery involved, but completed at the very end with restorative crowns so that when that patient has final closure, the condyle stays seated. There's contact all throughout, and there's immediate posterior disclusion, creating a perfected occlusion, managing forces. The last possibility is the red. So somebody comes in from your occlusal exam, you determine that there's medial pull problems, and there's a functional disc dislocation. And so what you do is you stop and you treat the joint. And a couple broad ways to treat joints is the first one is with splint therapy. And this is the most common. And so sometimes the splint therapy can last for a while. But the goal of it is to end up in a stable occlusion that the disc and the joint are stable. And we do that by creating a perfected occlusion in the splint in time. And time for it to, for the breakdown of the disc or the joint to stop and healing to occur. Sometimes there's some joint procedures. Here's a couple examples that could occur, and not so common though. Most often, medial pull issues can be resolved and treated through time with splint therapy. So what's the key take-home thought so far in this lecture? From the occlusion exam, determine if the patient is green, yellow, red. So what's our overall summary so far? Where have we come from, and where is a good summary of these first 6 lectures? Well, first we started and we talked about 3 major diseases. And so we talked about the inverted tripod concept and how that is a good mechanism for understanding a perfected occlusion, one that has been improved for stability and protection. And when we have a perfected occlusion, we showed you how then we have a peaceful neuromusculature. And then we shifted into dysfunction or non-peaceful neuromusculature. And we show that it can create muscle hyperactivity, which can potentiate breakdown and excessive forces of the joint, muscles, or teeth. And symptoms could occur in either the teeth, the muscles, or the joint, or none. And so a new patient comes, and we identify through an occlusion examination and make a diagnosis. And then we use that data that we gathered in order to categorize our patients into red, yellow, or green so that then we can come up with a treatment determination and what to do if treatment is necessary.